Hi, this is Mrs. Terry, and I'm going to be adding a video to your Unit 1 this week, trying to help go over some of the terms where you can hear some of these terms spoken, understand a little bit more in depth what it is that you're needing to learn for Unit 1. Unit 1 includes chapters 1, 21, 22, 23, and 24. I would highly recommend that you read all the terms in the beginning of the chapter. Make sure you understand every one of those terms. Also, at the end of each unit are very helpful notes. Just a minute, what they call key points that really are, to me, an overview of what it is that you need to know about some of these issues. There are some review questions, additional learning resources, etc. that certainly will help you master the content that are in these units. So in Unit 1, this is the overall unit about drugs, regulation, the ways the medications enter your body, how they're absorbed, etc. You know, there are intrinsic drugs and extrinsic drugs. Intrinsic drugs are drugs that are made that are within your body, such as insulin. Extrinsic, or from X, they are outside of the body, anything that we would give a patient that is not produced from within. Drug effects, there's the desired effect. The physician orders the medication, he wants to have an intended action, and when that occurs, that's a therapeutic response. When the medication causes a response in the patient's body. There are side effects and adverse effects. We certainly need to understand side effects. Usually that is things like headaches, nausea, vomiting, drowsiness, dry mouth, dry eyes, those sort of things. But then there's adverse effects, more serious effects that could certainly hurt the patient that you need to be aware of at all times. Those can be as much as hives, low blood pressure, tightness in the chest, severe coughing spasms, and we have pictures here of a person that's having a lot of edema and swelling. Nowadays you're hearing on the news about EpiPens and how important it is for these parents to have these EpiPens for these children due to these allergic responses. You know that drug names, there's a chemical name, a generic name, and a trade name. The trade name are the names that we're generally used to, such as Advil, Tylenol, that sort of thing. I'm going to go over this rather rapidly so we have time to go through it all. Moving on slide 10, we talk about high alert drugs, and those are in your chapter on page 5. And those are under memory joggers, and I would highly recommend that you study and learn all memory joggers that are in our textbook. Those are very helpful in understanding all of the material that you're going to have to learn this year. They provide methods to help you memorize certain terms or medications, that sort of thing. This one on page 5 is called PINCH, P-I-N-C-H. And it stands for potassium, insulin, narcotics, chemo, and heparin. So if you think of the word pinch, those are called high alert drugs. And those are drugs, as a nurse, when you're giving these medications, they cause you to take a second thought. Do I have the right vial of medication? Do I have the right strength? These are very potentially dangerous medications that you have to really pay attention to. Then we talk about drug regulations. You know, the USP is the pharmacopoeia that sets the standards for manufacturing and labeling and all of that. And then the FDA enforces those standards. So the USP sets the standards, develops the standards, and the FDA enforces it. Then we talk about terms such as potency, efficacy, and the potency is what you think of anything else. It's the strength of the drug. The efficacy is the ability to produce a more intense response as the concentration of that drug increases. And pharmacokinetics, we talk about the distribution of the drug, how it spreads throughout the body. It can go through the plasma, the interstitial fluid, or the intracellular fluid. You need to know metabolism, elimination, absorption. Absorption is the way the drug enters the body and passes through the body fluid. So how much of it gets absorbed. The bioavailability is how much, once that drug is injected into the patient, how much of it is available to help the patient, because drug medications have a span of life, and once they enter the body, some of that life goes away just through the process of entering the body. So the bioavailability is the amount of drug that truly reaches the blood, how much of that is available once it's in the blood. And that all depends upon the solubility of the drug, the route of the drug, how it was administered, and the degree of blood flow. So you know if a patient is anemic or whatever, or dehydrated, the ability of that drug to flow through the body is decreased. So the bioavailability of the drug then would be decreased. We talk about routes of absorption. There's percutaneous, which is the mucous membranes, enteral, which is the mouth or the GI tract, and the parenteral is anything having to do with a needle. So it's IV, IM, any of those. Distribution, as we talked about, is the way the drug moves through the body, through either the bloodstream, the interstitial, or the intracellular space. Metabolism is the chemical reaction in the body that changes the chemical shape and content of the drug. Meds are metabolized through the liver, the kidneys, and the lungs. So when you think about that, it's important for patients to have good liver function, kidney function, and good lung capacity. All of that has to do with how that drug is going to be metabolized in the body. The elimination, how that blood leaves the body. It goes through the kidneys. Again, if patients don't have a good kidney function, then that medication is not going to get eliminated correctly, especially like in the elderly. If their kidney function is not as good as it was when they were 20 or 30, then you can see how an elderly person, and then if you add on the fact that they're dehydrated, you can see how an elderly person, that medication could build up in their body, and it could become then very dangerous. Thus the reason you start watching labs and monitor your patient for all kinds of signs and symptoms once you give a medication. Blood pressure medicine, pain medication especially, all kinds of medicines. If they're elderly and have poor kidney function, poor liver function, poor lung capacity, then that medicine can build up in their body. Very, very important. So the medications are eliminated in the kidneys, lungs, via the bowel, and very small amounts in the other ways that I have listed. The first pass is once the drug enters the body, it's the rapid and inactivation and elimination of the drug. That's called the first pass. And we talked a little, I think, earlier about half-life and the bioavailability of medications. So your half-life is the time needed for half of the dose to be eliminated. Drugs can first be ordered as a loading dose, and that has a long half-life. So the physician would order a drug that he knows is going to last longer in the body. So he's going to give that as what they call the loading dose. And then you do that to get what they call the MEC, the minimum effective concentration up. So you want the most effective concentration first so that the patient gets that hit of that medicine. And so that is usually done through the loading dose. And then you do what the doctor will order, peak and troughs. And peak and troughs are the lab values that monitor how much the medication is in the blood over a given period of time. So make sure you understand all that. Then we're going to move on to Chapter 21, Drug Therapy for Asthma and Other Respiratory Problems. So if you want to turn to Chapter 21 in your textbook, let me get over there to it. Again, you need to learn the terms that are in the front of that book. Anti-inflammatory, bronchodilators, eucalyptics, all of that. There's a diagram here, of course, of the lung. And what we have here on the PowerPoints, pathology of asthma, and how there's a normal airway, asthmatic airway, and then an airway during an attack. And we have a comparison chart. Some of these charts are not in your book, so I would highly encourage you again to make sure you study these PowerPoints. But I have a comparison here of COPD and asthma. Asthma is a chronic disorder of airway constriction. So page 342 in your textbook talks about asthma being a chronic disorder. It's a disorder of constriction of the bronchial smooth muscles that surround the airway, and from inflammation in the airway. So the airways get inflamed, then the bronchial tubes constrict, and that's what causes asthmatic attacks. In asthma, make sure you understand the symptoms in asthma can come and go. As you probably know, some friends or family that are asthmatics. You need to always check their bilateral breath sounds on both sides. And they're usually normal between attacks. You don't normally hear wheezing, stridor, anything like that. So asthma then, because of that, because the airways can become normal, then asthma is a disease that is considered reversible. And there's no damage to the alveoli in the lungs. Now, comparison to COPD, chronic bronchitis, and emphysema, those are usually not reversible. COPD is a combination of chronic bronchitis and emphysema. It is a persistent inflammation of the airways. It is similar in terms as far as airway blockage as asthma, but these symptoms do not go away. There's permanent damage to the alveoli of the lung. It causes a thick, sticky mucus in these patients. And they usually take organodin or something like that to keep the mucus thin. So you'll hear even children have to take organodin, but that keeps that mucus thin. Then your slide here shows the difference between emphysema and normal lungs. You can see how those alveolar sacs are damaged. Page 343, then we start talking about bronchodilators. They relax the smooth muscles in the airways, causing the openings to enlarge, but they have no effect on inflammation. Bronchodilators relax those smooth muscles. Please remember that you have short-acting and long-acting bronchodilators. Make sure you understand the difference between those. Long-acting are used to prevent an asthma attack because their effects last longer. So they're used on usually a daily basis for asthmatic patients, long-acting. And they have no value in acute asthmatic attacks. So make sure you understand that on page 343. So on page 344, you have the common bronchodilators. Now this is where you need to start doing your outlines of your chapters and learning your categories of medications. So your heading would be bronchodilators. Then you have what I just talked about, short-acting, SABAs, long-acting LABAs, and then cholinergic antagonist. And you need to understand these medications in a test. I will ask you something about albuterol probably, or Ceravent, and I try to put the generic in the trade name. I don't always do that. So you need to understand and know these medications. It is a lot to understand, I realize that, but you have to know it when you're taking care of your patients. So common bronchodilators are what we call SABAs, S-A-B-A, long-acting beta agonist, which is a LABA, and cholinergic antagonist. I'm talking so fast I'm keeping myself from being able to talk. And so the cholinergic, and then xanthines, and that is on your slide under bronchodilators. So patient teaching to avoid asthma triggers. Make sure the patients know their medications they're taking, when to take them, what to watch for side effects, and you probably know weakness, nervousness, tachycardia, insomnia. When patients take a breather, a respiratory breather, something like that, it usually speeds up their heart rate. Then they have trouble sleeping. So they need to understand how to take that medication. There's an example here of on page 345 of a patient taking an inhaler with what they call a spacer, and need to learn what you're going to teach your patients. Okay. We also talk about inhaled corticosteroids. They certainly have been used for bronchial spasms, and those are listed there. Flovent is one of the most common. Solumedrol is another very common corticosteroid. Mast cell stabilizers and leukotriene modifiers. Those are all used for asthma. You have some combination meds that are used, and a popular one is Advair. We hear on the news all the time, and Symbicort. Those have both types of meds in them. Now on page 346, there's a note: when giving 2 or more drugs, give the bronchodilator first and then wait 5 minutes to give the other drug. Why would you do that? Because you want to give every effort of dilating those bronchioles that are constricted. So you want to dilate the bronchioles so that that medicine will get in there and work. So you wait 5 minutes, give the bronchodilator first, then wait 5 minutes. We talked a little bit about mucolytics earlier. That's Robitussin, Mucomyst. Those are given certainly with COPD and respiratory infections. Moving right along to chapter 22. This is drug therapy for gastrointestinal problems. Again, you need to know the key terms. Be sure you study all of your, this is a very good book. Study your drug alerts, study your graphs, and study all of the did you knows, the memory joggers, that sort of thing. The vomiting center is located in the medulla of the brain. That's what triggers our vomiting reflex, and that is involuntary. Nausea is the sensation to vomit. Retching is those labored dry heaves, and vomiting is the powerful contractions of the abdomen. Common causes: cancer meds, antibiotics, analgesics, pregnancy, viruses, migraines. Increased intracranial pressure can certainly cause vomiting. Antiemetics control the nausea. Page 358. Here are some common antiemetic drugs and the dosages. I probably will not be asking any dosage questions right now, though you need to understand how they're given. Orally, IM, IV, that sort of thing. And though you need to know the drug class and the names. So you have phenothiazines. Very common one that you may be given at the hospital now is called Phenergan. Very, very common when patients are nauseated, you would give Phenergan. Compazine, I don't know, is given all that much anymore over Phenergan, but compazine is another one that we give in a hospital setting or in a long-term care setting for nausea. Anticholinergics, scopolamine, antihistamines, cyclizine, mesclazine, that's Dramamine. You hear about Dramamine. And 5-HT3 receptors, or Kytril. Other ones, Zofran. Zofran is more of a common medication nowadays. You need to know that is used usually for chemotherapy patients, although I had a family member in the ER not long ago and they were given Zofran because they were nauseated. So it's a pretty powerful drug. I was surprised. But you need to know Zofran, that is the med that really helps chemotherapy patients nowadays. Years ago, Zofran wasn't on the market, and you always heard about chemotherapy patients having such a hard time with the nausea. Well, now they're receiving Zofran, and it can be given IV or sublingual under the tongue, and it really helps our chemotherapy patients. Then you have a dopamine antagonist, and one of those meds is Reglan, which is a very common medicine that is given before meals and at bedtime, that sort of thing. So you need to know this category, these drug classes for antiemetic drugs. Then the side effects. Be sure you understand the side effects of these drugs. And as you see, a lot of it, and over here on the right hand, page 359, dizziness, fatigue, headache, blurred vision, constipation, a lot of dry mouth. You have, with Phenergan especially, Compazine, a lot of those, you have a lot of dry mouth problems, fatigue, blurred vision, constipation. You have a lot of the same side effects. Now, interesting here on the bottom of 359, Compazine, the one I keep talking about, can cause a decrease in sweating and increase the risk of overheating of the body. Very interesting to understand that and know you need to monitor your patient, especially if they're a man that won't follow doctor's orders and rest. He goes outside, he's taking Compazine, and he gets has a heat stroke, something like that. So that can happen. We need to always monitor the respiratory rate and status of our patients who are taking some of these medicines because, as we talked about earlier, age, if they're not have good kidney function or good liver function, these medications can build up in their body and can cause respiratory depression. So we always need to watch our patients when we're giving them any medicine. But that's why it's particularly important for you to pay attention to your vital signs and how important taking, nurses don't need to just go and I'm going to take their vital signs. You take vital signs for a reason, and the reason is to find out how your patient is doing, especially if you've given them medication. One quick note, the medication Reglan on page 361 can cause depression. Very interesting note to remember. So you would ask your patient before you give them Reglan. The family member I had is not depressed but elderly, and they didn't ask us anything about that. So and many elderly patients are depressed. So nowadays Medicare screens. That's the 2 screening questions that Medicare has for elderly patients nowadays. If you're in a doctor's office, do you feel joy in life? Do you feel like projects are still interesting to you? So a lot of elderly patients are depressed. Then you say you give them Reglan, and boom, you've got a problem on your hands. So important to know about Reglan. So they should not take a central nervous system depressant while taking a lot of these antiemetic drugs. So if they're taking a medication for depression, and then they take some of these antiemetics on top of it, it can double the problem. Okay, now we're going to move on to page 362. We're going to talk a little bit about constipation. We know what that is. The bowel movement should be soft and easy to pass. Consistency is more important than frequency. So it's more important that they consistently have a bowel movement. Ask about their daily routines. Check about their diet. Do they have fiber in their diet? Milk, Physical activity, medical problems. Do they take opiates or calcium supplements or iron? Of course, iron. Do they have a high fiber diet? Do they have lots of fluids? And do they exercise daily? All of these, if they don't do, can give them problems with constipation. Metamucil is the one medication that can be used regularly to help avoid constipation. Important to know, years ago a GI doctor told one of my patients that he could take Metamucil every day for the rest of his life and it would not harm him, where these other medications, stool softeners, laxatives, are not intended to be used on a daily basis. But Metamucil is still the one medication. It is a bulk forming laxative, and it can be used daily. Then we need to know the common drugs for constipation on page 364. Now you see, again, they're in categories. It's important for you to diagram this, learn these categories. You have bulk forming drugs, emollients or stool softeners, emollients combined with a stimulant, just a stimulant. You have osmotic laxatives and lubricants. And you need to know how each one of them work. How do they work? In other words, an osmotic laxative causes fluid to be retained in the bowel, increasing the water content of the stool. So osmosis, it pulls that water into the bowel and causes that stool to be looser. The others, lubricants, that's an oil, and that is mineral oil or one of the glycerin suppositories. So that helps that stool to move through the system. The stimulant does just that. It stimulates the colon. Stool softeners, and then bulk forming that we talked about earlier. So very interesting how each one of these medicines, that's why I like nursing so well, to think that each one of these medicines work in a different way on the body. Moving right along, we're going to talk just briefly about diarrhea. You know what causes it, and that the types of drugs are anti-motility drugs, so those that slow the motility of the GI system down, absorbent drugs, and that's absorbed into the GI tract, and anti-secretory drugs, which is like Pepto-Bismol. One thing about Pepto-Bismol, please remember, do not give that to a child. Pepto-Bismol, or to someone who potentially maybe has a severe allergy reaction to aspirin. You'd have to ask your physician. But for children, Pepto-Bismol contains a chemical like aspirin, and due to Rye syndrome, we do not give Pepto-Bismol to children. All right, then we're going to move on to gastric ulcers. Not a good thing to have. Rapidly, our time is winding up. We have the different on page 374. If you will look, it divides the stomach into sections, and so you have gastric ulcers, duodenal ulcers, and esophageal ulcers, and the various places where those occur. There's a memory jogger on 374. It's called the H. pylori bacteria. That bacteria is the primary cause to 80% to 90% of all GI ulcers. There is a test that the gastroenterologist can do, and he can check for the H. pylori bacteria in you or your patient, and if that's present, then they can treat the ulcers. A lot of patients don't have that bacteria, but they can still have an ulcer. But the majority of patients do have that. That is what causes 90% of the ulcers. Then you talk about GERD. You've all heard about GERD, gastroesophageal reflux disease. And what causes GERD? Overweight, pregnant, certain diseases, peptic ulcers, certain drugs, drinking, and caffeine, or alcohol, eating high acid content like tomatoes and orange juice, eating fatty foods, spicy foods, laying down too soon after meals, and smoking. All of those are risk factors for GERD that you can help your patients with. And there are lifestyle changes on page 378. What would you tell your patient to do? Stop smoking, quit drinking, exercise, avoid tight-fitting clothes, elevate the head of the bed, avoid eating 3 hours before bedtime. Then you have different anti-ulcer drugs, histamine 2 blockers, proton pump inhibitors, and cytoprotective drugs. And those are listed in the next 2 pages. Common H2 blockers are Pepcid, very common, Zantac, very common, and Tagamet, very common. Proton pump inhibitors, Prilosec, Protonix, Nexium. You hear about Nexium in advertisements. Those are proton pump inhibitors. Need to know what those do. If in any of these medications, if the patient has black tarry stools, you need to notify the prescriber. Black tarry stools are an indication of some type of bleeding that may be going on. And then you have antacids on page 283, Maalox, Milk of Mag, Mylanta, Amphigel, Tums. All of those are drugs that neutralize acid in the stomach, just like the word is. The most common side effect of antacids containing calcium or aluminum is constipation. So you need to tell your patients about that. So any meds with calcium or aluminum can cause constipation. Many elderly people take antacids, and then you have that problem. Most of the drugs that are used for cytoprotective drugs are just like the name is. They protect the exposure of the stomach to acids. So they protect open sore areas in the GI tract. They do not coat the normal stomach mucosa, they just protect. Moving right along, pro-mobility. Okay, be sure, I told you before about on page 387, children should not be given Pepto-Bismol and black tarry stools. I really wanted you to understand that. Okay, then quickly, chapter 24. This is about drug therapy with nutritional supplements. So we talk about fat-soluble vitamins, water-soluble vitamins, trace minerals, etc. We have human bodies need 13 vitamins. The 2 major groups of vitamins are water-soluble and fat-soluble. And water-soluble are listed on page 24. And vitamin C, you need to know which vitamin and what the deficiency or the action could be. So again, I won't ask you dosages, but like vitamin C can cause scurvy. Niacin can cause pellagra, thiamine, beriberi, B6, anemia, hair loss, and that sort of thing. Folic acid aids in protein metabolism, red blood cell formation, and lowers the risk for neural tube birth defects, etc. So you need to know the vitamins. Then on the next page are the fat-soluble vitamins, vitamin A, D, E, and K. A is, you can get night blindness if you're deficient. Vitamin D, which many people now are being found to be low in vitamin D, causes rickets. It regulates calcium and phosphorus metabolism. And vitamin E helps with electrical impulses. Vitamin K prevents bleeding. So if a patient is having some sort of a brain hemorrhage, you will see that the physicians order vitamin K. Be sure, and you will hear about this again, if I think I've already told you, but we teach patients to always avoid salt substitutes. Salt substitutes contain potassium, And if a patient is already receiving a potassium supplement or something like that, their potassium is high because they're dehydrated, whatever, then they take a lot of salt substitutes, then their potassium is going to increase that much more. The next 2 pages are on the minerals in the body, very, very interesting. And here's where we talk about potassium. It's needed for fluid balance, nerve transmission, muscle contraction. You know, when your potassium is low, how people said they get leg cramps. That's the muscle contraction. Sodium is needed for fluid balance. Calcium, of course, bone density, etc. So you need to read all of that. Enteral feedings are preferred as long as the GI tract is working. So we give enteral nutritional supplements through a tube, often through the stomach, and you will learn to insert those tubes into a patient's stomach, and then you would give feedings through that, and those are called nutritional supplements. Diarrhea is the main side effect of these supplements, and so again, you watch the elderly or children, but anyone, but the elderly especially, and you're giving them these nutritional supplements, and then they're having diarrhea. So then what does that do? That increases skin breakdown, dehydration, just makes them extremely tired because you're wearing them out trying to take care of them. So it's, you try to help the patient, and then we cause sometimes some bad side effects. So that roughly took about 45 minutes for you, and I hope you find it very helpful. I know I talked really fast, but you go over your slides, you learn those slides, you read these chapters more than once, and hopefully this helped. Thanks. Bye-bye.